Burns refer to tissue injury caused by exposure to heat, chemicals, radiation, or electricity. So there are multiple factors that could lead to injuries we call burns. There is a separate set of slides showing what these different burn types look like. So if that's something you're interested in, you can check that out on Beachboard. In this country alone, there are about 500,000 victims of burns receiving treatment. Among all the factors, heat burn is the most common cause. It accounts for about 80% of all burn patients. So heat burn being from being basically thermal burns, so anywhere from sunburn to being caused by flame. The clinical manifestation and the signs and symptoms of burns are determined by how deep the damage is and how big the damage is in terms of percentage of the body's surface area. This figure shows how to estimate the percentage of body surface area that is burnt. We call it the rule of nines. So if we look at this figure, different parts of the body are divided based on the factor of 9%. For example, if we're talking about our head, if the front part is burned, it's 4.5%. If the back part is burned, that's another 4.5%. So the entire head accounts for 9% of the total body surface area. So if we move down, for example, we have the arm. The entire arm, one arm, is 9% of the body. The front of the arm is 4.5%, and then the back is also 4.5%. Then the chest, the entire front of the chest is 9%. The upper chest is, the upper back is also 9%. So this here is a very straightforward tool. It's very useful to estimate percentage of body area, the surface area that is burned. Also, how deep the damage done by the burn affects a patient's recovery and survival significantly. So we know that there are 4 layers of our skin. If it burns down to the bottom one, even deeper into the subcutaneous fat or the muscle tissue, then the regeneration of the skin will become impossible. So that's why we classify based on how deep the burn is. So we go down from superficial all the way down to full thickness. So a first-degree burn would be considered a superficial burn. Second degree, there's kind of 2 here. There's a second-degree superficial partial thickness and a deep partial thickness. And then a third-degree burn would be considered this full-thickness burn. If we do reach full thickness, we can see that the healing time is never. So therefore, it causes permanent damage. Obviously, if this is the case, then there would be other parts of therapy we need to consider because this part of the body is completely lost. And there will be permanent changes in the body if the patient survives. Therefore, we need to be prepared. So this down here is just showing us the 4 layers of skin. So the first degree, we just have the top layer, the epidermis. Second degree, we're getting down into the dermis being burnt, and then third degree all the way into this subcutaneous. So the condition caused by burns is characterized by hypermetabolism, catabolism, as well as altered immune and hormonal response. So this is very typical for what we see stress and metabolism. And we have covered, and what we have covered in metabolic stress really applies here significantly, everything that we've talked about. Moreover, depending on the severity of a burn, the hypermetabolic stress caused by the burn may persist for up to 2 years post-injury. The open wound may have healed long before that, but the metabolic rate is still elevated for quite a long time. So that is how significant the impact can be. Due to the nature of the injury, during the ebb phase, so that initial stage, the first 48 to 72 hours, the patient will experience massive fluid loss. So therefore, that becomes the focus of the initial treatment. The fluid loss can be caused by the burn itself, because we know that heat, by burning the soft tissue, it will cause a lot of fluid loss. But once the damage is done, before the open wounds heal, more body fluid will be lost through evaporation from those wounds. This is the reason why for burn patients we want to put a dressing or cover, something to protect the wound, because that will lead to additional loss. If we leave the wound undressed, the fluid will evaporate. So there will be significant loss of body heat as well, because as we know in the laws of physics, evaporation decreases temperature. So we are talking about a potentially large surface available for fluid evaporation. Many burn patients have respiratory complications, including respiratory failure. This could be caused by inhalation of smoke or other hazardous chemicals at the site of the burn. And of course, in this case, the inhalation is not confined to only the burn victim. It can be seen in emergency responders such as firefighters. Also, due to the metabolic stress caused by burns, respiratory complications could be a result of the trauma and the infection that may come after the burn. So this could be part of the systemic response, or even part of the multi-organ distress syndrome, or multiple organ failure. The management of burns requires intensive intervention and the specialized care for the healing of the respiratory, the cardiovascular, and renal systems. So all these three systems we have mentioned previously. These are the focus of support for patients under metabolic stress from burns. Definitely all of them will be applicable. Because the damage involves a lot of open wounds, there has to be specialized wound care treatment. So there will be topical agents. We mentioned covering the open wound. Not only does this reduce the risk for subsequent infection, but it also prevents further loss of fluid and body heat. There may also need to be the removal of dead tissue over time, and eventually, if we have some undamaged skin saved, we can use that to grow more skin and do skin grafting. So that will obviously be a much better and organic way to treat burn patients, because if we're using the patient's own surviving skin, it's an auto transplant, so therefore there won't be any rejection. And what's depicted in this image over here is a graft taken from another part of the body that did not receive any burns, so that's healthy skin. And then they go ahead and put it through a machine to mesh it. So that's what causes these little holes in it. And that basically allows the skin to be spread out, so it covers a large amount of area. So they don't have to remove as much, the same amount of skin. They can remove a smaller amount of skin to cover a larger portion of the burn. Because when we think about it, when we're taking the graft, we're causing basically another wound here. So the smaller in size that can be, the better it is for the patient. So burn patients are at a significant nutritional risk because of the metabolic stress. The hypermetabolic and catabolic response could lead to the loss of up to 20% of body protein. So this is a very significant amount of lean mass loss. In a previous lecture, we showed the table indicating when a patient loses 40% of lean mass, mortality becomes 100%. So a burn itself could lead in the loss of 20% of body proteins, so it's very severe for these patients. Also, along with nutritional implications, we have a fluid imbalance. So on top of the regular fluid shifts that we see in all metabolic stress conditions, burns specifically affect fluid status. There will also be a lot of pain, which in itself, in addition to making the patient very uncomfortable, the pain increases the energy requirement and the patient will not be mobile due to the damage. And then with healing itself, we know this requires optimal nutrition, including energy, protein, and a lot of key micronutrients as well. When we assess burns, we should know that most of the burn itself and the stress response caused by the burns affects nutrition parameters. So patients may have a weight fluctuation. Specifically, when we assess the patients frequently, we may see weight loss due to significant fluid loss. Then we may see rapid weight gain if the patient undergoes fluid resuscitation. Also, weight loss can be contributed by the protein loss. So remember, it could be as much as 20% of total body protein lost during this process. To estimate the energy requirements for burn patients, indirect calorimetry, of course, is the best way if we have it. This method has becoming more and more popular, and in many units, it becomes the standard to estimate energy requirements for burn patients. So there's evidence that supports the use of indirect calorimetry in this population. So we measure patients under the fed states, then we should have a reading. Then with the reading, we want to round it up to the closest 100 calorie. But this rounding should not exceed 10% of the measured value. Again, as you've previously learned, when it comes to calories, it's not necessary to be as specific to say like 5 calorie, 1 calorie, or 0.2 calories. We can always round up. And there is evidence that for burn patients, we can round it up to the closest 100 calorie if it doesn't exceed current limits. And we do have an equation called the Curry equation developed for burn patients. But studies indicate there is a severe limitation for using this equation because this equation seems to be best to assess the patient's needs at their peak injury caused by the burns. But we know with proper intervention treatment or if there's deterioration, burn patients' conditions can change rapidly. So if there is significant day-to-day change, whether it's progress or deterioration after the initial burn, then this equation is not the best to use. So just to kind of show about this equation, we can see that it uses actual body weight, and we only provide about 25 calories. So that's, a pretty typical amount. And then we do add extra based on the percent of total body surface area that is burned. So the TBSA is total body surface area. So looking again at these two components of the equation in this first one, so this is what we would basically need to maintain the needs. So 25 again, 25 calories, that's not a huge allowance. And then, so this is basically just maintenance for adult patients. And then the second component is what is needed to address the increased requirements in this condition. So therefore, we want to know very well what this equation requires. So we need to know actual body weight and percent total Burns, total body surface area that's affected. And we should also know the limitations of this equation, being that it best assesses the patient at their peak injuries caused by the burns, so it may not be appropriate to use throughout treatment. Overall, the protein requirement is based off of kilogram of ideal body weight, so 1.5 to 2 grams of protein. So if we consider in general the metabolic stress patient's needs for protein, that's usually 1.2 to 1.5. So that's already much higher than the RDA for protein. So therefore in burn patients, it's even higher. It's higher than other metabolic stress conditions in general. So even with this high amount of protein provided, it's still less likely to prevent nitrogen loss. So recall what we saw in that graph that had the curve of nitrogen loss. Burns will have a very high peak nitrogen loss through the urine, and this increased nitrogen loss lasts a very long time. So if we remember that figure, the curve shows about a month or longer. And today we mentioned that sustained hypermetabolic status could persist for 2 years post-initial burn injury. Also, if we're talking about children, we may provide even higher amounts of protein because we know at that stage of life, children need more based on kilogram of body weight. They need more to support their normal growth and development. So when they suffer from burns, they will receive a higher protein allowance compared to adult patients. However, studies have shown no advantages in providing over 2.2 grams of protein per kilo in adult burn patients or 3 grams per kilo in children. So these are commonly used nutrition problems when we're writing the PES statements for burn patients. So these are all pretty typical, and we did mention most of these in other metabolic stress conditions. When we provide a nutrition intervention, one goal is to prevent Curling's ulcer in the duodenum. So Curling's ulcer is actually an acute peptic ulcer in the duodenum. This is a type of stress ulcer. So remember when we talked about GI disease, we talked about the peptic ulcer disease, the gastric ulcer that's caused by excessive acid in the stomach. And when we talked about that, we also mentioned stress ulcers. So this is a case of a stress ulcer because the whole system is under metabolic stress. So that's what we're seeing as a result. And we really want to, again, modulate the immune response and address the physiological stress level and prevent this duodenum ulcer. At the same time, we want to avoid overfeeding. This is also a theme very common in treating critically ill patients under metabolic stress. Because remember, if we provide too much nutrition, it actually does more harm than good. As in other metabolic stress conditions, patients often have hyperglycemia, and That's due to the metabolic stress. Therefore, we will need to have intensive insulin therapy to address this. And enteral nutrition is preferred over parenteral nutrition, of course, and because the early initiation of tube feeding is associated with better clinical outcomes, that's something we want to try to achieve. In tube feeding, we can provide a supplement in omega-3 fatty acids and also glutamine. Because omega-3 is anti-inflammatory, that will help calm down the systemic inflammatory response. And glutamine is an amino acid that is helpful with wound healing, among other things. Although how much glutamine should be used is still under investigation, so we really don't have a strong guideline on that one yet, unfortunately. If we are using EN, the tube feeding may not be enough to provide an adequate amount of energy and protein, so we could consider a combination of using EN and PN. Then when we resume PO diet as the patient recovers, we will obviously gradually increase the amount of PO diet and at the same time decrease the nutrition delivery through nutrition support, whether that's EN or PN or both. Eventually, when the PO diet can meet at least 60% of the patient's needs, this is the time that we can safely discontinue the nutrition support. We talked about the energy and protein requirements, and we mentioned we will need to supplement the formula with additional active ingredients. So this table lists those ingredients. We already mentioned glutamine, and we also mentioned omega-3 fatty acids for their anti-inflammatory properties. So these minerals here, zinc, selenium, along with these vitamins, vitamin C and E, are very helpful. So when you discussed wound healing and advanced nutrition, we learned that it's very common to give the patient a combination of micronutrients, for example, zinc and vitamin C. So zinc is a mineral that can regulate gene expression, and vitamin C is essential for normal collagen protein synthesis. Therefore, they are both required to make new tissues and to repair the damage and help heal the wounds. So all of these vitamins and minerals listed in here function as antioxidants and modulate cell replication. So they're involved in nucleic acid metabolism, tissue repair with collagen and protein synthesis, as well as growth. So all of these should be provided together with adequate protein and adequate energy. And because wound healing is an anabolic process, we for sure would need to supply extra.